You have the pharynx, and then the esophagus where it travels down into the stomach. The stomach then goes to the small intestine, the large intestine, rectum, anus, and then evacuation of stool. So the movement of the muscles in the digestive tract, starting with the esophagus, is called paras. It is like this squeezes, then this squeezes, then this squeezes, then this squeezes to move the food downward to the stomach, and then the digested food then through the small intestines, and then stool through the colon. Okay, defecation is going to be absorption. Majority of absorption happens in the small intestines, the lower stomach and small intestine area, and then defecation is going to be the rectum and anus. This is a reflex when the rectum gets full of stool, and then Valsalva maneuver is the active, forceful pushing of stool out of the body. It is that bearing down. So if you want to kind of read through the little notes that I have, there's more about the anatomy and physiology. So I'm just going to scroll through here, and you can pause if you need to take your own notes. Okay, common bowel diagnostic tests or screening. So for stool analysis, I've only got 3 listed there. Hemocold, with the slides that I pictured here. Guaiac is just another word for that. And then the fecal occult blood test, this is where it's kind of a corkscrew looking probe that you mark the stool, or you have to puncture the stool in several locations depending on manufacturer and lab protocol, and then that gets sent to the lab to be tested. It's supposed to be more accurate than the slides. Other tests that we can do for stool analysis, we can do cultures, like for C. diff or some other infection. We can look for white blood cells, ovum, and parasites, which is called an OMP. And then for x-ray, we can do where we have a flat and an upright, or maybe just a flat abdominal x-ray where we have them lay down and then we have them stand up. It shows then we can see the differences and tell what's going on. So here we can see, like there's kind of a bulge here that maybe there's an obstruction. You can also see too, like when it's distended, like this is an abnormal distension of colon. Barium x-rays, upper and lower GI barium x-rays. So barium is a type of contrast that we use to really define what is going on. So that's why this is lighting up so bright. For lower GI, this is going to be done by enema. For an upper GI, like for the visualizing the esophagus and the stomach, it's going to be like an oral prep, a PO prep that they're going to have to drink. So very important, though, that patients that get barium x-rays done, that they have to have laxatives after they're done, because if they don't have laxatives to get that barium out, that barium can dry like concrete in the intestines, and then we worry about obstruction and that kind of thing. So lots of laxatives to help move that out. Plus laxatives need water on board, so lots of water as well. Direct visualization can be done through what's called an endoscope. So whenever you see scope, you think of a camera. An EGD is going to be looking at the esophagus, the stomach, and in that first small intestine segment, the duodenum. And then we can do a colonoscopy or sigmoidoscopy to look at the large colon. Pre and post-op procedures. So for pre-op, there's usually a prep that's done. It's usually like clear liquids for a day, and then there's like a lot of, and each doctor has their own procedure that they like. Some of them it's meg citrate, some of them it's just taking a whole bunch of stool softeners, some of them it's go lightly, and some of them it's a mixture of all those things plus like Miralax or something. What's very important to note though, like we don't want people to use orange or red, like Gatorade, if that's in their thing, because that can look like blood in the intestines, and that's certainly not a good color that a doctor wants to see there. So the purpose of that is cleaning the stool out from the intestines so they can actually see what's going on in there. Some other preps might include an enema before it's done. That's been quite common that people will get an enema before going in for a colonoscopy. just to make sure the bowel is very cleaned out. Even like a soap suds enema to help kind of irritate the bowel to really get it to eliminate correctly. Post-op, it just depends on, did we do conscious sedation with this, or were they completely knocked out? So if they are completely knocked out, that's with general anesthesia, so that you have to do like, the vital signs every 15 minutes or whatever that protocol is. If it's that conscious sedation, that usually takes longer for people to come out of, but they don't have to have those risk factors also with general anesthesia. And I'll kind of go through here again so you guys can see my notes. Oh yeah, and colonoscopy, people are placed on their left side, as probably saw on here, left Sims position, so knee bent. All right, bowel focused assessment, so things that we're looking for. So these are the 4 main assessment things that we do for the bowel, looking at the abdomen, right? So these are out of order. There's a specific order to these, and it's going to be inspection. First, we're just going to look, and then we're going to listen. We're going to auscultate. From there, we're going to palpate, so feeling around, see if we can feel any lumps or if the patient has a tender spot, something like that. And then percussion is when we listen for the resonance by tapping on our fingers, listening to see what is hollow sounding versus what is solid sounding. And then subjective data, this is going to be what we hear from the patient. Subjective data, so like bowel pattern, how often do you go? What is it like? Did you have any changes in your bowel pattern recently? What foods do you usually do? There's a lot that can go into it. Medications, we know medications can affect bowel pattern. So there's medications that can speed it up. Drugs even like caffeine can speed it up. Nicotine can speed it up. And then laxative use, anything like that. Lactulose will speed up bowels. And then there's things that we know will slow them down, like narcotics, or even like an Imodium or Lomotil, things like that. Anxiety or stress, this can take bowels either way. It can cause constipation or it can cause diarrhea. It's kind of up to a person's how their body is responding to stress. And then surgical, we need to know their surgical history. If they've had any kind of abdominal surgery, that could lead to scar tissue that could impact bowel function. So it's important to know those. I have in my notes here auscultation, a normal bowel sound is active, and that means you hear it gurgle every 5 to 20 seconds. And if you're not hearing anything, you should listen for at least 5 minutes, 2 minutes per quadrant also, before you can call them absent. Stool assessment. So we've gone over this before. Frequency is whatever that person's norm is. If they go once a week, then that's their norm. If they go 3 times a day, then that's their norm. It's when they have changes in their normal pattern that's when we, get concerned about it. So normal color is going to be brown because that's, the bilirubin going in. Abnormal colors, black and tarry. Well, we know that could mean blood. That can also mean iron supplements, or even Pepto-Bismol can cause stools to turn black or brown. I'm sorry, not brown, but like kind of a dark greenish black. And then reddish brown we know can mean blood. Maroon also blood. Bright red blood would be blood, right? Clay colored would be liver problems. Yellow green, what they're talking about here is like infection yellow green, like there's pus and stuff with it. Otherwise, to have just like a green bowel movement doesn't really mean anything. It could just be because of what you ate. It's not necessarily abnormal. Consistency, soft and formed. Abnormal would be very hard or loose liquid, or maybe a lot of mucus. Shape, cylindrical. Abnormal would be narrow or pencil thin. Amount, I've never weighed stool before unless it was a baby, so if you have to weigh it, there you go. Odor, aromatic to pungent. Bad, objectionable, foul odor is going to be abnormal. Okay. Fecal diversions, make sure you look in your book and review these on your own. Something to take note though, stoma. A stoma, this is where they've taken, part of the intestine and it's now an opening to the outside of the body. What a normal stoma looks like is this bright, beefy red, and it looks moist. It's shiny. It has moisture to it. That's a normal stoma. Now, if it's pale, if it's pink, if it's green, those would be abnormal. Pale or pink, we're worried that it's not getting the perfusion it needs. If it's looking a little green, like there's discharge and stuff, then that maybe it's infected. So those are things that we look at for a stoma assessment. Whoops, sorry, I went too far. And then a colostomy bag is usually going to be attached if this is a colostomy. So that would mean that it's on part of the colon. If it's an ileostomy, it's going to be in part of the small intestine. So just like I have here, colonoscopies are going to have more formed stool, harder formed stool. Ileostomy is going to have liquid stool because it hasn't gone through the colon yet to have the water absorbed out of it. Also look up J pouch and Cook pouch in your book and make sure you know what those are. All right, I'm going to stop there and then we'll continue with intestinal obstruction.